So my name is Nicole Cyberlick, and I'm from the University of Michigan. And I'm delighted to host our journal club this week. We have two articles that we are potentially even more if Dr. Pakizer is going to present more than one. But we have a couple of articles that we are looking at today on the topic of carotid plaque characterization. So the first set of papers we're going to look at will examine the diagnostic accuracy of MRI when it comes to detecting plaques and sorting out some of their characteristics. And then we're going to move on to a second paper which talks about the quantification of carotid plaque composition using a technique known as match MRI. So I'm actually quite excited about this. We don't necessarily do a lot of vascular imaging talks in this setting, so I'm really happy that we're getting to the cardiovascular part of cardiovascular imaging. So with that, I'm going to hand over to Dr. Pakizer for your presentation. Are you able to share? Is it working?
Yeah, I'm trying.
Okay.
So can you see my screen?
Yes. Yep. We're good.
Great. So I'm David Pakizer. I'm from Czech Republic, University of Ostrava, and I'm assistant professor of imaging methods, Department of Department of Imaging Methods at the University of Ostrava. And I did my PhD on a non-invasive imaging of carotid plaque features, carotid plaque characteristics. So today I would like to present you our diagnostic accuracy project, and it will be not only here the systematic review about magnetic resonance imaging, but also very shortly, very briefly, the results of the meta-analysis. So I choose to present you this poster that I presented during the annual meeting of European Neuroradiology Society because it's quite better compared to the very long manuscript. The manuscript has, I think, 27 pages because a lot of citations and a lot of tables. So why we decided to do the diagnostic accuracy meta-analysis on a non-invasive imaging modalities in detection of carotid plaque composition? It's because carotid atherosclerosis is very common in our population, particularly in the older population, and carotid atherosclerosis is responsible for approximately 25% of all strokes. You know that the degree of stenosis was always considered the main risk factor for stroke, but over time it was found that plaque features likely plays a key role in the risk stratification. So we have non-invasive imaging of carotid modalities, and we are able to detect the composition of carotid plaques. So there is a lot of diagnostic accuracy studies with small sample size. Sometimes the results are very often not quite similar, as you will see here from the results of our systematic review on MRI. So there is a vast of literature on the carotid plaque features. So we decided to conduct a comprehensive study because comprehensive studies on the topic are lacking. So our aim was to analyze the diagnostic accuracy of MRI, but the aim of the whole project was to include also computed tomography and ultrasound. But here I'm presenting you the systematic review on MRI. So the diagnostic accuracy of MRI in detection of carotid plaque features in patients either symptomatic or asymptomatic. Yeah, that's it. So we included We included all the adult patients. We included the ultrasound, computed tomography, and MRI. And our reference standard was the true histology assessment. And the histological analysis should be conducted within 1 month from the imaging of the carotid plaque. So as you can see from the figure number 1, right corner, the prisma flow diagram, at the beginning we identified over 8,000 studies. In the end, we included into a systematic review 53 eligible studies. So we found 37 diagnostic accuracy comparisons between MRI, some of the sequence, some sequence of MRI and histology, and we identified 37 those comparisons using 1.5 Tesla machine and 17 diagnostic accuracy comparisons using 3 Tesla MRI. Here you can see the results in the middle of the poster that we found that the diagnostic accuracy of 1.5 Tesla was much better compared to 3 Tesla. Regarding almost all of the characteristics you can see here, we were able to present 13 different plaque characteristics in 169 comparisons of diagnostic accuracy. So at the beginning, intraplaque hemorrhage, which is considered the strongest predictor of stroke, the characteristic at risk. So you can see that the mean sensitivity for 1.5 Tesla was 86%, mean specificity 88, very good, but you can see also the range. Not here for 1.5, but if you just check the other here, the 3.0 Tesla, so you can see the large heterogeneity in the results. If you consider the range regarding the specificity, the range is not so wide, but if you check the original paper, so regarding the 1.5 Tesla and other plaque characteristics, you will see very large heterogeneity. So, but of course, very high sensitivity and specificity was found for intraplaque hemorrhage, lipid-rich necrotic core, also calcification. Here the 3 Tesla machines were better compared to 1.5 Tesla. Very good sensitivity specificity also for fibroscap. We included the rupture fibroscap, also thin or thick, just some type of the fibroscap. And you can see here also the rest of the results. Finally, in the end, we also suggested the preferred sequence and preferred appearance of the plaque features on magnetic resonance imaging. You can see here the table number 1. We also included here the importance of contrast enhancement magnetic resonance imaging in the second column from the right, and also we presented the evidence based of the strength that we found in the published study from the systematic review. So you can see that we found a lot of studies regarding intraplaque hemorrhage, and all the studies were uniform, that the preferred sequence is MPRH because of the highest sensitivity, the highest diagnostic accuracy found in those studies. And you can see that also the appearance of the intraplaque hemorrhage on magnetic resonance imaging was quite uniform, because as we showed here, the intraplaque hemorrhage appears as a hyperintense on T1 weighting. So we concluded that MRI showed a high diagnostic accuracy and able to detect a high number of plaque features, 13, regardless of the strength of the magnet. So 1.5 Tesla is very good for the routine use. The results emphasize the role of MRI as a first-line imaging modality for complex assessment, not for the basic evaluation of carotid stenosis, carotid plaque. So for a complex assessment of carotid plaque morphology, particularly regarding high-risk features of instability. The manuscript was published in Journal of Medical Resonance Imaging last year, and you can check it, of course. However, I would like to also show you I don't know why I have here those lines.
Yeah, I think those got there by accident with just a annotation tool, but you could just ignore them for now.
Oh, okay, sorry.
No, I think it wasn't you. It's okay.
Okay, so here are also the results. Sorry. Here are also the results of the meta-analysis, because we aim to compare the diagnostic accuracy of magnetic resonance imaging, computed tomography, and ultrasound in detection of individual characteristics. As you see here, the paper published in Atherosclerosis just recently. We included 107 studies investigated 16 different histological carotid plaque features detected by CT, MRI, or ultrasound, and we concluded that the CT proved superiority in detecting the basic features like ulceration, calcification, but also very good diagnostic accuracy for intraplaque hemorrhage. But of course, the ability of differentiation between intraplaque hemorrhage and lipid-rich necrotic core is limited, but based on the published evidence, we can say that CT proves superior, very good diagnostic accuracy also in detecting intraplaque hemorrhage, the same as MRI. Ultrasound is very good for a basic screening. The diagnostic accuracy of US of ultrasound was also not significantly so worse compared to CT and MRI. And MRI is very good for the complex assessment of carotid plaque. And the second part of the results regarding our diagnostic accuracy meta-analysis published in European Heart Journal Cardiovascular Imaging is focused on plaque instability, so on stable or unstable carotid plaque based on the papers included from the systematic review, and also we differentiated the individual carotid plaque features on a group of stable or unstable, and we also revealed the results, but I don't have here the results, but I can just briefly say that the ability of CT and MRI was quite similar in detection of unstable carotid plaque, which is very good. So it is very good to use a CT in the acute phase to evaluate also the stability of carotid plaque, and ultrasound was significantly less accurate compared to MRI and ultrasound. So if you are interested, I'll also recommend you to check the results of the meta-analysis, not only the systematic review on MRI. So that's it from me. So thank you for your attention, and I'm happy to answer your questions.
Perfect. Thank you so much for sharing this a very detailed analysis with us. If there are any questions, you can drop them in the chat, or you can raise your hand or just unmute yourself and go ahead and ask. While we are waiting for questions from the group, I have my first question, I guess, is so you mentioned that 1.5T had a higher diagnostic accuracy than 3T. Is that correct?
Yes, regarding the specific plaque feature and based on only on the results of a systematic review.
Got it. And do you know why that might be? Like, are there characteristics of 1.5T that might make it easier to assess these plaque characteristics?
I think that we have a solid evidence from 1.5 Tesla studies regarding the basic features and using also the basic magnetic resonance sequences. But regarding the 3 Tesla studies, I think the studies are more focused on a development of new sequences and trying to use those sequences for detection of a particular plaque features. So therefore, the diagnostic accuracy of those new sequences are sometimes very heterogeneous.
Got it. Oh, we have a question from the audience. Go ahead.
Yeah, thank you so much for it's nice presentation, but I wondering, Hori, the main question in your study is to compare 1.5 versus 3. So I don't know if that's fair comparison because, for example, if you want to look for a specific feature like intraplaque hemorrhage, it should be compared based on the sequences. So for me, it's if you want to say we can detect intraplaque hemorrhage on 1.5 or the sensitivity of detecting intraplaque hemorrhage on 1.5 Tesla higher than 3 Tesla, that in which sequence? What do you mean? Because on time of flight, on MP range, on TSE, T1. So for me, it's a little bit confusing. I don't know if you can elaborate more on this.
Yes, Dr. Kassem, thanks a lot for a question. Very good. The main focus of our study was not to compare 1.5 Tesla to 3 Tesla, but just to present the diagnostic accuracy evidence where some of the magnetic resonance machine was used to detect some carotid plaque feature, and the reference standard was histological assessment of the plaque. And of course, from the search strategy, we found a lot of 1.5 Tesla studies and also a lot of 3 Tesla studies. So at the end, we just presented the separate evidence from 1.5 Tesla and for 3 Tesla. So of course, it's very it's very good that you said that we have to investigate the different sequences. Of course, I will just show you the article here. I said that a lot of tables are included, so we wanted to show you every sequence that we were able to found in those diagnostic accuracy studies. So you can see here the specific sequence here for intraplaque hemorrhage, for example. At the beginning, there are only 1.5 Tesla studies. Number of patients included, the appearance of intraplaque hemorrhage on MRI and also on a histology. And here is also the sensitivity and the specificity of the study and of the specific sequence. Regarding the intraplaque hemorrhage, because this is the mostly discussed carotid plaque feature, we are preparing also sub-analysis, so diagnostic accuracy meta-analysis of the specific sequences used to detect the intraplaque hemorrhage. And we will also do and we will also consider if the study is using 1.5 Tesla or 3 Tesla machine.
But then can you, for example, from your experience and from this meta-analysis, tell me if I want to use MPRH on 1.5 Tesla or on 3 Tesla, which one is the best to detect IBH?
Regarding the results of the published studies, the 1.5 Tesla is enough. I think, or here in our country, there is most of 1.5 Tesla machines that are widely available, and you can refer the patients very easily for the MRI examination on 1.5 Tesla. Regarding 3 Tesla is much more difficult. So our study presenting the result that the 1.5 Tesla has a very good diagnostic accuracy if you use MPRH in detection of intraplaque hemorrhage. And you can see here all the details or all the evidence that backed our conclusion that 1.5 is enough. Here is also the 3 Tesla. Yeah, here's the beginning. And the diagnostic accuracy is, of course, also very good. But as I said, the 3-point Tesla studies are mostly using not the very basic MPRH sequence, but here you can see the mapping sequences, the match sequence that you will talk about. Yeah, another match, and you can see also the diagnostic accuracy of the match is quite good. Yeah, so regarding the MPRH, the majority of the studies of our evidence is coming from 1.5 Tesla, and based on those results from 1.5 Tesla, I can say that MPRH is very good, superior for the routine investigation of intraplaque hemorrhage.
So I'm afraid in the interest of time, we're going to have to move on to our next speaker, although I'm really very happy that we've had such a good discussion. So great. I'm glad to see that Dr. Kassem is here, and I'm going to hand off to him for the presentation of the paper which describes this match sequence, which we've been talking about.
Yes. Yeah, good evening from the Netherlands, maybe good morning in US. Yeah, it's a great pleasure actually to present our paper. It's published in Frontiers in Cardiovascular Medicine in 2023. Actually, I wrote this paper and I investigated here during my PhD under the supervision of Professor Elena Coy, which she is also attending this journal club, maybe for further elaboration or question, maybe also you can ask. She is a medical physicist, so she has a lot of experience of because I left actually this domain to other things. But it's great pleasure to present the paper here. So first of all, thank you so much for the first presentation, which is actually put some important point actually to start my paper as well. So for me, it's very important to highlight very important things. Intraplaque hemorrhage, lipid core, fibrous cap status are risk factor for stroke, for primary stroke and also for secondary stroke. And in order to actually to detect these features or these compositions, we called multi-sequence multi-sequences. And that's actually needs long scan times, more than 30 minutes. If we include the preparation and this stuff, we need maybe 40 or 50 minutes. And there is also some limitation because we are looking to these features in multiple sequences. We need to co-register this image together. And that's also make the analysis difficult for junior researchers or junior doctors, and also take a lot of time. So the aim of this study actually to compare the quantification of this plaque composition on the multi-sequence, the conventional one, but with the new sequence, it's called match. I'm gonna come in a few minutes for the details in for this sequence. So as MRI is the preferred non-invasive modality to visualizing plaque compositions. And usually the expert consensus said and published a paper, they said, for example, if you want to detect intraplaque hemorrhage, MPRH is the best one. If you want to see the calcification, you need to look to time of flight. If you want to look for the lipid-rich necrotic core, you need to use contrast-enhanced T1 weighted image. And as I said, there are some limitations. Some sequences, 2D sequences, long acquisition time, and image misregistration. The new proposed sequence is called multi-contrast atherosclerosis characterization match. It's mainly actually to quantify and to identify plaque features. It's match. And it acquired 3 different contrast weighting: hyper T1 weighted image, gray blood, and T1 weighted image. And in general, intraplaque hemorrhage on match image, we look to the intraplaque hemorrhage in the on the hyper T1 weighted image on match. And for calcification, we look on the gray blood. And for lipid necrotic core, we look on T2 weighted image. As I said, here it consists of 3 for hyper T1, IPH, gray blood for calcification, and T2 for lipid-rich necrotic core. In our study, actually, we include symptomatic and asymptomatic patients, but at least they need to have at least 2 millimeter ipsilateral carotid artery, either in the duplex or on the CTA. For the image analysis, I want to also highlight that during the analysis for the multi-sequence, we do the manually co-registered while using specific software called VisalMass, while for match image, actually, it's already inherited. Its co-registration is inherent, and we don't want to require any additional manual adjustment. And here all the match and multi-sequence carotid MRI protocol. There is a lot of parameters here. I can go directly to the figures maybe. And yes, for example, 27 patients underwent match and multi-sequence carotid MRI. So we analyzed ipsilateral and contralateral arteries. 1 artery excluded because it's total occluded. And then 53 carotid arteries were used to study the IPH, the intraplaque hemorrhage and calcification and fibrous tissues, and also plaque burden. We need to also exclude 2 patients because we could not inject contrast, that we cannot assess the lipid-rich necrotic core. So at the end, 51 carotid arteries were analyzed to delineate lipid-rich necrotic core. Okay, here the characteristic of the patients. There is no same patients. Okay, so first of all, we want to compare the quality of the multi-sequence protocol and the match protocol. As a conclusion, we found that the multi-sequence protocol had a higher qualitative image quality comparing to match when we compare hyper T1 weighted image versus MPRH, because those 2 we use to detect intraplaque hemorrhage. So we compare head to head. So the image quality of MPRH higher than T1, hyper T1, and time of flight higher than gray blood, and also the post-contrast T1 is higher than the T2 match. So as a conclusion, the image quality of the multi-sequence is higher than the image quality of match. Then we look to the detection, the inter-observer agreement between the multi-sequence and match. For example, if we want to look to the presence of lipid-rich necrotic core, we found that there is agreement actually between the match and also the multi-sequence of detecting lipid-rich necrotic core. Same for IPH, kappa is 0.8 in multi-sequence, and also in match 0.4, 0.84. And for the presence of calcification, of course, multi-sequence protocol showed higher detecting rate of calcification, because we looked not only on the time of flight, but we looked to another 2 sequences in order to see if there is calcification or not. While in the match, we only were able to look on only 1 sequence, which is gray blood. That's why the detection rate of calcification was lower than the multi-sequence protocol. But also for the quantification of these compositions, there is actually higher intercorrelation coefficients between match and between match and the multi-sequence protocol. Same when we did actually for Bland-Altman plots. Let me see here. I can make it a little bit low. Okay, so this is Bland-Altman plots actually for 2 readers of detecting specific plaque features. For example, here, myself and another reader, we detect the volume of lipid-rich necrotic core on match and also on multi-sequence, and we see that there are actually quite correlation or between both readers in detecting lipid-rich necrotic core, intraplaque hemorrhage, and also calcification, and when we calculate also the normalized wall index. Then we calculate the sensitivity and specificity of detecting these plaque features on both protocol. If we look to the specificity on the MPRAGE, on the multi-sequence protocol, we showed actually higher specificity of detecting intraplaque hemorrhage, and high also sensitivity between both protocol. Same for the for lipid-rich necrotic core for both readers, while for calcification, actually, that's the agreement, or there is low sensitivity and low specificity of detecting the calcification and on match comparing to the multi-sequence protocol. Maybe you can go a step back here. If I look to this multi-sequence protocol here, we can see here multi-sequences, MPRAGE, pre-contrast, post-contrast, and time of flight. Intraplaque hemorrhage can be identified as a high signal intensity within the plaque of the plaque. While the post-contrast, we can see the lipid-rich necrotic core, and for calcification, we see also low intensity in the bulk of the plaque. For the match, and this image, we need to co-register the image manually, while for match, they are already co-registered, and we see also the intraplaque hemorrhage as a high signal intensity on the hyper T1, and in the gray blood, we see the calcification, while in T2, we can detect the lipid-rich necrotic core. And also we tested this against histology, and there is actually agreement in specific cases. I think we have 2 or 3 cases with histology, and here an example of this. We can see the intraplaque hemorrhage and within the histology, and that's in the same patient on multi-sequence protocol and also on match protocol. Then we tested also Bland-Altman blot actually for between 2 protocols for both readers, and we see that there is no bias actually for reader 1 and also reader 2 when we quantify the volume of lipid-rich necrotic core on both protocol, and same that also for intraplaque hemorrhage and for also calcifications. For normalized wall index, also the results was also good. Yeah, and that's it for this paper. I'm happy if you have any question to answer.
Awesome. Thank you so much for presenting this work. It's really interesting to see how those images that are collected simultaneously compare to the ones that are collected individually. That's very cool. If there are questions from the audience, again, you can raise your hand or you can drop a question in the chat. But maybe I can ask a question to start too. So it looked like the match acquisition, so you're collecting like basically three different like signals that are sensitized to, you know, slightly different characteristics of the tissue in order to get like the T1 weighted, the T2 weighted, and the gray blood. Is that right? Got it. And is there something that you would add to that, like a fourth contrast or a fourth piece of information, like in particular to try to get at the calcifications, so to kind of improve the ability to visualize them?
Yeah, indeed, a great question. Actually, that's will bring me to actually very important result that maybe I didn't present it here, which is the analysis time also of the black features and also the scan time. As we said that this sequence or match sequence needs only 5 minutes to acquire three different weightenings. And within these three different weightenings, you can detect all and quantify, not only detecting and quantify the most important plaque features, intraplaque hemorrhage, lipid-rich necrotic core, and also calcification. So while in the conventional multi-sequence protocol, we need 30 or 40 minutes actually to acquire that. Now, if we want in the daily clinical practice, I'm always thinking after this paper, the aim was how we can facilitate detecting plaque features in the daily clinical practice, because it's quite actually difficult to say to the patients, okay, we need to go to the MRI machine to do 40 minutes scan and only to detect intraplaque hemorrhage. With a match, within 5 minutes, you can acquire this sequence and you can detect most plaque features or vulnerable plaque features. If we can add to match, for example, time of flight, which is also sometimes can be used as a daily clinical practice. So in this 5 minutes plus, I think 3 minutes time of flight, then you are able to detect also calcification with high specificity and sensitivity. So actually, it's this paper can help the clinicians to adopt detecting plaque features in order to use it as a prognostic or as a feature in order to determine the type of treatment. As you know that until now with the carotid stenosis, they are only looking to the degree of stenosis, not to the vulnerable plaque features. And there is strong evidence at the moment, actually, intraplaque hemorrhage is very strong feature that can detect or predict recurrent stroke. So with match, in addition to maybe time of flight or T1, you can detect most plaque features.
Perfect, thank you. Are there any other questions? Oh, yes, go ahead, Dr. Pakizer.
Yeah, thanks. Great presentation. I just have a question regarding the match sequence because I found only a few papers on about that particular sequence. So I just have a question about the clinical practice. Are you using the match sequence for example, stroke patients where you don't know, the source of the stroke? So are you using in clinical practice the match sequence? And do you think it is better to use the match sequence, for example, compared only to MPRH to look only for intraplaque hemorrhage? So do we need to look on a different plaque features? Or for a clinical practice, is it enough to look only on intraplaque intraplaque hemorrhage?
I don't know actually how to answer this question, because intraplaque hemorrhage easily you can acquire MPRH, and that's the gold standard, actually MRI gold standard sequence to detect intraplaque hemorrhage, and that's sufficient and that's enough. However, there are a lot of research proof that not only intraplaque hemorrhage is a risk factor, but other like fibroscap status. fibroscarp status, then you need to acquire post-contrast T1 weighted image. In the daily clinical practice, at the moment, at least, I don't know, maybe Professor Koy can comment on this later on. And I don't know at the moment if they are using any sequence in the daily clinical practice to detect, for example, vulnerable plaque features. Two years ago, at that moment, we were proving in the second European carotid surgery trial the importance of intraplaque hemorrhage to decide the type of treatment. I don't know if the result is published or not, but at the moment, I don't think they are using any sequence to look into vulnerable plaque features.
So maybe I can add to it. So in the Netherlands, we're now doing going to do a large trial. And then it's also, of course, very important that a sequence is actually a product, so that it works in every single hospital. And I think so now the match sequence is not a product yet. So in our large trial in the Netherlands, we are going to use mainly MP-RAGE because it's a product, it's available in every single hospital. And I think if there is more evidence from the trial that plaque imaging can really change and reduce recurrent strokes, then I think this also will motivate the vendors to build these advanced sequences such as match in a product. But at the moment, they have not.
Okay, thank you. So are you still testing the match, or are you trying to use specifically the match sequence?
Well, at the moment, we are more focusing on how we can use plaque imaging with MRI in the clinical decision making. And we are investigating whether it actually improves the outcomes of the patients.
Okay, thank you.
Excellent. All right, I think in the interest of time, because we've gone way over, we're going to wrap it up, but I really very much appreciate both of our speakers today. I think this was really an excellent journal club, and I know I learned a lot about the plaque characterization using MRI, so this was amazing. I would like to remind everybody that we have our next journal club on November 5th, so a month from now. And we will be featuring Dr. Shinoy, who is going to be talking about some work he's been doing on cardiovascular magnetic resonance phenotyping. So using information from CMR to make decisions about the use of implantable cardioverter defibrillator devices in patients with cardiac sarcosis. So this is going to be, I think, a very exciting journal club, and so I hope that you will join us then. And in the meantime, I also want to wish everybody luck if you are submitting an ISMRM abstract, because that is happening in between now and our next journal club. So yeah, happy submitting, everyone. And hopefully I'll see you all back in a couple weeks. Have a good, a happy October 1st.
Thank you.
Thank
for the
you.
invitation.
Bye-bye.
Bye.